He's a fellow of the
Now,
Royal
coming on to
College
the
of Physicians
fourth
of London
issue
and the American.
is the issue of suicide. Suicide is a big problem, and this takes you through the spectrum of the phenomenon, ultimately culminating in a completed suicide. The point I want to make about all of this is that people, PWE means people with epilepsy. People with epilepsy who ignore seizure-related risks and are non-adherent for no otherwise identifiable reasons may be parasuicidal. So when you have a patient who's not taking their medications and yet is having major consequences from it, physical consequences too, social consequences from it, think about this as a possibility. That's the point I want to make about this slide. Overall, the suicide risk, I mentioned it in relation to surgical series, but the usual scenario is a male patient living alone, family history of suicide. Those are the background things that apply to anybody for epilepsy, for suicide. But with a background, schizophreniform psychosis, and on drugs that can cause depression. And remember, as Winston alluded to in the context of drug addiction, availability. If you're giving them drugs like barbiturates in large quantities at home, right there, they can use it how they want, including in this way. Jans, the same person who I said described juvenile myoclonic epilepsy, summarized this very well, and I quoted it directly from a paper. Patients at risk of suicide are not characterized by a particularly severe course of epilepsy. In their biography, suicide marks a point of culminating critical personal and social decisions, which often have become urgent by way of an effective therapy. You make them well from their seizures. And what's their scenario? No hope. They're really thrown out into society. The final thing to talk about is psychogenic non-epileptic seizures in the context of psychiatric disease. Because remember, I'm tying up this talk by talking briefly about behavioral things. Up to 40% of seizure patients in general neurology clinics do not have epilepsy. Think about that. And in specialized monitoring units, up to 20% of patients, and in fact at Columbia it was 30% of patients admitted for potential surgical evaluation for apparently intractable epilepsy had psychogenic non-epileptic seizures. Clinically, these things can mimic seizures very much, and that is the reason, right? But the process is very different, and Winston will be able to explain this much better than me. But I felt the best concise paragraph that explains it is that these come from non-conscious psychological processes that convert psychic conflict into symbolic somatic symptoms, meaning the seizures, for primary or secondary gain. Remember, this is a conversion disorder, while simultaneously preventing conscious awareness of the intent. In other words, this is a purely unconscious phenomenon. Sexual abuse is very common. The typical clinical picture is a young woman comes in to see you. And when you take the history, and you don't get this history immediately, it takes time. You have to build a rapport with the patient. But about 50% of patients with psychogenic non-epileptic seizures have a history of sexual abuse. Other major life stressors are well recognized too, and minor head trauma with disability claims may also be a phenomenon. But the big and overriding thing is sexual abuse in childhood. How do you diagnose this issue, this thing, psychogenic non-epileptic seizures? It can be very challenging, and I'm going to list this in a table in a moment. The features, generally speaking, can mimic many different types of epilepsies, but the big thing is psychogenic non-epileptic seizures often coexist with epilepsy. The patient can have both. Remember the concept of primary gain and the concept of secondary gain. And I've listed them here. If we need to discuss this in more detail, we can later. Obviously, it allows the patient to express an inner conflict suppressed beforehand. Actually, just yesterday, on Friday, I saw a patient in whom the 17-year-old girl, she revealed to her mother, after having had seizures for 4 years, she does have epilepsy, primary generalized epilepsy, that and she was having these rare seizures, which didn't make sense. The semiology or the clinical phenomenology described was incompatible with the epilepsy syndrome that I knew she had, raising the question as whether they were psychogenic events. She told her mother that her uncle had abused her at the age of 4, and this happened on Friday. I know these things, let me just say something quickly before I forget to say it. Psychogenic non-epileptic seizures are far harder to manage than true epilepsy. Pause for effect. Now, there are other ways in which psychogenic seizures may arise rather than through conversion disorders, malingering, anxiety, and so on, or it may coexist with conversion mechanisms. And here's the interesting thing about these patients. We would think that stress should lead to them having seizures, but in fact, stress is more recognized as a trigger for true seizures than psychogenic events. Also, think of the phenotype. The patient who goes often to the emergency room, uses multiple medications, high doses of anti-seizure drugs. That sounds like refractory epilepsy, but that could be the scenario of psychogenic epilepsy, because anti-seizure drugs are not going to work for them. You can give them as much as you want and as many as you want, still not going to work. Obviously, they're going to go to the ER uncontrolled. And that's why these patients end up going to specialized units for evaluation for apparent medical intractability. They don't have epilepsy. And when you have a patient who has an atypical emotional reaction, think about it too. Crying or apparent label indifference, lack of concern for the event. These things should raise a red flag. But equally too, crying can be a manifestation of seizures, so-called dichristic seizures. These things are very complicated. And self-inflicted injury does not necessarily mean it's true epilepsy. Patients can be injured, they can injure themselves and so on. Seizures that arise from sleep. It used to be thought if a patient was fast asleep, there's no way it could be psychogenic. But patients can wake up and not let you know. And the only way you could know that is if you're monitoring them by simultaneous EEG overnight and see that, in fact, they actually do wake up before the event. And the point I'm making with my last slide is that patients with epilepsy can elaborate on a simple partial seizure. So they say they have a tingling in the hand, and they may then elaborate that to a bizarre phenomenon that makes you think, oh my God, this is a purely psychogenic issue. But you miss the fact that the onset was with a true seizure. This is how complex the topic is. It is very, very difficult. And often, many of these patients will have a past or current epileptic history. Generally speaking, though, there is some similarity. And I can go on and on and on, but I want to actually list the things to you. Oh, by the way, right hemispheric dysfunction is often seen in these patients with non-epileptic